Okay. My name's Louise Hull, and my topic today is really a bit of an introduction for all the other speakers. And it's entitled How Thin is Too Thin and When? And it's really referring to the thin endometrium. I have some conflicts with research funding, and several pharma companies and IVF media companies have supported my research over the years. This is my first slide. So essentially, it is what's defining a thin endometrium. And the thin endometrium is really defined by an ultrasound finding of a lining that doesn't measure very thick. And there's still some controversy about exactly what the measurement is that is defined as thin. But most papers look at using a measurement less than 7 millimeters. However, there have been some papers that have looked at it when it's less than 6 millimeters. And there are a couple, and certainly one very large study that have used 8 millimeters. And I'll explain some of the studies that we're looking at today and why they've chosen that range. And I think one of the things that we can take from this is that it isn't very clear exactly when we would define something as having a thin endometrium that would have an effect on a pregnancy. And certainly that's what the studies are showing. So first of all, just how to measure the thickness. And there's a very good paper by a Canadian group who've really defined how to take a measurement. And essentially you want to use a transvaginal scan, make sure that the bladder is empty, and then measure the endometrium in the sagittal plane or the longitudinal axis. You want to measure the thickest echogenic area between both of the stratum basalis interfaces. So you want to measure from here to here, and you don't want to include this darker area that's the myometrial interface. And it's usually about 1 centimetre from the top of the fundus. So that's the kind of measurement you should be getting, but you should look at the thickest part. Sometimes it's actually really quite hard to take that measurement, and I've put a lot of slides up here. About 10% of the time, there's something that will preclude you from having a good measurement of the lining. And this is an example of adenomyosis, where you really can't find the myometrial endometrial junction very easily. Here there's a fibroid, and it's just making the cavity very thick, as is this polyp. And then in situations here, we have actually a caesarean section scar and a collection of fluid, and it's quite hard to measure the endometrium in that situation. Or this is actually Asherman's, and there's just little pockets of fluid amongst the adhesions, and it's very hard to see the endometrium. So sometimes you can't take a good measurement, and that would be about 10% of the time. Most of those things, however, do need a surgical opinion. And many will require surgery to fix them. The other thing that's really important when you're measuring the endometrium, and I very much like this picture here, is that when in the cycle you take the measurement makes a big difference. And as you can see, we're just after a period, and when the endometrium is repairing, the lining is very thin. It's about 2 millimeters. But then by the time you get to the end of the proliferative phase, it's around 11 millimeters, and it has a very trilaminar appearance. And as you can see, however, that's not the peak of endometrial growth. The peak of endometrial growth is in the secretory phase, and you see this much more homogeneous picture of the endometrium, and this is about 14 millimeters thick. However, for a clinical perspective, what we want to do is know when it's the right time to trigger, or when it's the right time in an IVF cycle, how thick the lining is before ovulation. because then we can change things. We can change doses, we can change medications. So we're generally measuring just before ovulation. So in practice, and most of the research papers take the day of the trigger or a GnRH agonist trigger. In a natural cycle, it would be the day of the LH surge or the HCG trigger. And in an artificial cycle, it's before we start the progesterone. So it's before pre-ovular is when we want to take the thickness of the lining of the womb. So how prevalent is a thin endometrium? And it isn't that prevalent. So when you, a large meta-analysis showed that the number of people who had an endometrium less than 7 millimeters was about 2.4%. And when it was less than 8 millimeters, that was the 5th centile. So about 5% had an endometrium that was thinner than that. So 95 to 97.5% of people have an endometrium that's above 8 millimeters. And the question is then, why do we need to know about it? Is it important? Does it make a difference? And there's lots of reasons why people have felt that it might be worth measuring the endometrial thickness. So the last part of my talk is going to be a little bit more about why we might measure the endometrial thickness. And there are several reasons you might want to do that. Firstly, if we want to predict pregnancy outcomes. So, you know, does a thin endometrium predict whether you would get pregnant or not? We can use it to determine the likelihood of pregnancy. Can it be used to determine the risk of miscarriage or ectopic? And then other questions are, can we use it to make a decision about deferring a transfer, or to initiate treatments that might increase the thickness or change the pregnancy outcomes? And I think a lot of these questions, some of these questions we've answered, some of them we've got some information on, but certainly the last two, I think we're very uncertain about still. So the first one is endometrial thickness predictive for pregnancy? And this is a ROC curve. Essentially, if it's a good predictor, we'd expect all the data to be up in this left-hand corner with high sensitivity and specificity to determine the thickness, that the thickness would determine whether someone got pregnant or not. And what you find is it really is not predictive. It's about 50-50 as to whether you would guess whether that would be, whether someone would get pregnant or not. And it really can't be used as a test for, like a test for pregnancy. And that was a large meta-analysis of 22 papers in 2014. What they did look at was, is it associated with a different chance of pregnancy and ongoing pregnancy? And when you looked at ongoing pregnancy in this large meta-analysis, the chances of live birth in an ongoing pregnancy were lower in women who had an endometrial thickness of less than 7 millimeters, but it didn't reach significance. And it was partly because they probably needed larger numbers. There did seem to be, the thinner the endometrium, the chance of pregnancy became lower. When they looked at clinical pregnancy, there were a lot more studies that just looked at clinical pregnancy as opposed to an ongoing or live birth. And they did find that the probability of a clinical pregnancy was significantly lower if women had an endometrial thickness of less than 7 millimeters. There was a positive predictive value. So if you had a higher, a thin endometrium, you were less likely to have a pregnancy, but the negative predictive value was very low. So a reasonable number of women with a thin endometrium did become pregnant, and you couldn't tell someone if they had a thin endometrium that they wouldn't. So it makes it very hard to know whether to defer a transfer, particularly if you have somebody who you've struggled to get the endometrium thick. Another reason you might want to know about the lining of the thickness of the lining of the womb is if it predicted miscarriage or ectopic pregnancy. And if the lining was thin, you might anticipate that either the placentation wouldn't develop very well or that the embryo would be in the tube. And there is another study. This is a big study that was done after the meta-analysis from China. And it was a retrospective analysis, but it had more than 10,000 fresh IVF cycle transfers, and they measured the lining on the day of the trigger. And with that large data set, they were able to look at the 50th centile and the 95th centile. And they found the 95th centile was in fact having an endometrial thickness of under 8. And as you can see, the 95th centile the other way was having an endometrial thickness of over 14. And they divided these groups of people into 4 groups, on the basis of each woman's endometrial thickness. So when you have a look at the data that came from the study, it really verified the data from the meta-analysis, which showed that there was a difference in pregnancy rates with the women with lower endometrial thicknesses having only a 23% chance of pregnancy, but the rate went up with the thickness even beyond 14 millimeters. And the highest rate was in those who had the highest endometrial thickness. So there was definitely a correlation between pregnancy rate and the high endometrial thickness. However, even women with a low endometrial thickness had a rate of 23%. So a reasonable number of those women did get pregnant. In terms of live birth, should people get pregnant, they still had a good chance of carrying a baby to a live birth. And again, there was a higher chance when the endometrium had been thicker, but there was still a 63% chance for women with a low endometrial thickness of carrying a baby to term. So it's hard to tell people to defer a transfer, particularly when in repeated cycles the lining's thin. And I'm sure all of us will have experienced somebody who had a thin endometrium who became pregnant and carried a baby to term. What, however, they did find was that the chance of a miscarriage was reduced as the lining got thicker. And the chance of an ectopic pregnancy was much higher when you had a thinner endometrium. And these were all statistically significant, but in actual fact, especially with an ectopic, the chance was higher at 10%, but most didn't become ectopic pregnancies. So there certainly are correlations with the endometrial thinness and thickness with pregnancy outcomes, but there are other factors that probably have more of a sway on the chance of having a pregnancy, such as embryo quality and maternal age. So there is some prediction, but it's not the sole factor and it's not the primary factor. So when we have a look at it really, endometrial thickness doesn't predict pregnancy outcomes. The ROC curve showed us that. It does have some implication for predicting the likelihood of pregnancy. And there's a little bit of data to suggest that it may allow you to be more suspicious of miscarriage or an ectopic, but the numbers are still fairly low. And the meta-analysis could not assess those parameters because the numbers weren't high enough. What it doesn't do is it doesn't give us a diagnosis as to what's going on in terms of pathology. And then the other factors that would be really helpful to know, which is really why we're doing this talk, is whether it can help us make a decision about deferring a transfer or initiating treatments to increase the endometrial thickness and the pregnancy outcomes. And I'm very lucky to have other speakers really addressing these factors a lot more. So it's quite a controversial area, but the other speakers will talk to you a little bit more about both the causes of a thin endometrium, but also about the clinical management. I think it's really important to realise that an ultrasound diagnosis of the thin endometrium, it identifies an observed phenomenon. It's not a pathology. And there are lots of different causes. And it's been speculated that low estrogen or poor vascularity, perhaps alterations in the growth factors in the endometrial cavity, infections like TB and endometritis or Asherman's are all different causes and potentially all need different forms of treatment. And it's actually really hard to treat something when you don't understand the cause, because if you're treating with an agent that increases vascularity, when in fact you need to be treating Asherman's, you're going to have potentially two different treatments. And I think we really need to start getting a better diagnosis of the underlying pathology and then really targeting our treatments to that. And we can't really even research them without being sure about the causal nature of the lining, to include people into a study that looks at treatment modalities for a particular cause. I have to reiterate that I'm very fortunate to be working and part of a symposium with some very distinguished speakers. And I really would recommend listening to them, reviewing the latest literature and some of their original research in terms of treatment of the thin endometrium. And I do think this is an area that's quite controversial and that we need a lot more research on. I have written down some resources and review papers that are very interesting for people who are interested in this topic. And certainly Nalini Mahajan's and Dr. Sharma's paper is a very good review, and it's relatively recent. Yuan et al.'s paper is the paper with the very large number of embryos, and looking at the details of that is a very helpful resource. Cassius et al. Did the meta-analysis of endometrial thickness and pregnancy rates, and that's a very interesting read as well. And then there's some very good guidelines that have come out from the Canadian Fertility and Andrology Society in the last paper, and I think these are very helpful papers if you're interested in this topic. Finally, I'd like to say thank you very much for letting me speak. And I'm looking forward to catching up in the workshop where we can answer questions, but also it'll be great to hear the other speakers' talks and their views on management. Thanks so much.